Good evening and namaste, friends and colleagues. Welcome tonight. It's really a pleasure to be here. I think we just witnessed the power of technology. I think you, like me, I think we all spent a lot more time concentrating on the words of the screen because of those black boxes. So that was a good way to introduce things. The impact that our collective work has had in India and that we've been able to collectively achieve has been truly remarkable. Through the power, the collective power of our partnership, we've literally saved lives, altered livelihoods, altered life trajectories, and contributed to the learning and the exploration that underpins our shared democratic values. I want to first start by thanking all of our poster presenters today for their hard work in preparing for today and showcasing the amazing work that our Indian partners, together with our collaborators at Hopkins, have been able to achieve. There's a saying, if you go to a muffler shop, you leave with a muffler. So, as a public health professional, I'm going to start by saying a few words about public health in India. However, as I do so, I want to reinforce the breadth and the depth of our collaborative work across Johns Hopkins that extends well beyond public health and medicine and includes nursing, engineering, business, education, and so many other disciplines. In fact, our ability to continue to deliver highly successful and impactful collaborations requires interdisciplinary efforts that bridge all of these disciplines together effectively. The vision of the Bloomberg School of Public Health at Hopkins starts with saving lives, millions at a time, and it embodies the collaborative work that Hopkins has been fortunate to be part of in India. Since 1990, India has realized exceptional improvements in the survival of mothers and children. Between 1990 and 2020, the maternal mortality ratio declined dramatically from 556 to 97 maternal deaths per 100,000 live births. During this period, under 5 mortality also dropped precipitously from 3.4 million child deaths in 1990 to just 824,000 in 2020. These declines have resulted from significant investments by the government of India across many domains of health and development, including education, immunization, improved access, and quality of health care. I have been fortunate to work closely with an amazing colleague and mentor here in India throughout the early years of my career. Some of you may have known Dr. Rajban. Dr. Ban once told me that if you want to have truly global health impact at scale, you must work in India. The numbers are staggering, and the human potential is unlimited. These declines have resulted from significant investments, as I said earlier, and Dr. Ban really encouraged me to focus in India and to leverage these investments to see and to realize dramatic improvements in health and development. He was absolutely correct, and in a moment you're going to hear some specific examples of collaborations that have led to this impact. I do want to just highlight a couple of examples from the Bloomberg School of Public Health that I think have had and will continue to have massive public health impact here in India. First, the Johns Hopkins Uttara Pradesh Health System Strengthening Support Project provides technical and advisorial support in collaboration with partners in the areas of health system strengthening, training, and analytics. Cyrus Engineer and other health systems experts from our school have worked closely with the government of UP to co-develop strategies to improve human resources for health. And they've improved health resources across the state, developing a plan for strengthening government health institutions and improving the use of data for decision-making. Secondly, I want to highlight the India Primary Healthcare Support Initiative, IPSI, which supports government initiatives to deliver comprehensive primary health care. In combination with AIMS, IIPH, the State Health Resource Center of Gujarat, and Jhpiego. IPSI supports the Ministry of Health and Family Welfare in developing a framework for assessing the performance of primary health care systems. These are just a couple of examples of ongoing work that is making and will continue to make the type of measurable differences in the lives of many that we seek to achieve. So we've done so much, as you saw on the slides, but there's so much more to do. Where should we go from here? Clearly, we have to continue to redefine our collaborations, continue to aspire to more equitable partnership with true mutual benefit. We must focus our efforts more strategically, and no area currently is perhaps more ripe with opportunity than the intersection of health and AI and data science. As we heard yesterday from President Daniels in another forum, Hopkins is placing an enormous bet on this future, and we look forward to participating with all of you here and all of our partners in India, to use these tools and these methods to continue to deliver impact at scale around the world, starting right here in India. Thank you. Thank you so much for being here. It really is quite meaningful for all of us. I want to welcome now Professor Mathu Santhosam to come and share with you some examples, some additional examples of the impact that we've made and continue to make together. So thank you so much, Dr. Santhosam.
Thank you very much, Judd. Judd is always a very hard act to follow, especially when he's already given all the whole talk that I was going to give already. So, but this is an extraordinary privilege to stand before you. I went to the Jhpiego, Pondicherry, which many of you may know, back in the 60s. I think some of you were not born when I went to medical school. Quite a big proportion, I think, probably were not born yet. But I have watched India grow from a time where we were losing a child every 6 seconds from diarrhea. There were 5 million deaths throughout the world. And of course, 20% of those deaths were right here. And something that is not recognized often by people around the world, and even here in India, one of the biggest discoveries, according to the Lancet, the most important discovery of the century was oral rehydration solution. And guess where it started? Right here. My mentors, like Bradley Sack, Nate Pierce, and others, worked here in the 60s at the cholera lab in Calcutta. Many of you may have heard of Dilip Mahalanobis, who made major contributions. Because of that one, are my slides going to be shown? Okay. Okay. All right. It's not working, so we'll have to manage without technology. But the fact is, India. Oh, no, this is the last slide, so I want the first slide. Yeah. Okay. So I went to Pondicherry Medical College. And this pointer doesn't work. The guy in the circle with lots of hair is me. And the one thing I suggest, if you want to keep your hair, don't immigrate to America, because you lose all your hair there. So. But this is just a very, very small selection of what has happened between Hopkins and India. Oral rehydration, as I told you, is an example of reverse transfer of technology, where the technology started in India and then taken back to the USA. USA did not accept oral rehydration therapy as standard treatment until 1985. And it took another 2 decades to actually get it into the system and get people to use it. And as you know, oral rehydration is now estimated. Can I do next slide? Oh, yeah. Has saved at least 50 to 60 million lives in the last 4 decades. And people don't realize it started here, then moved to Dhaka in Bangladesh, and then all over the world. The diarrheal deaths that I saw when I was in medical school and what used to happen here is something most people in this room do not appreciate. Rows and rows of beds of kids trying to get IVs. Those IVs didn't work often. nosocomial infections, didn't have enough people. Such a tragedy. And that's now changed. But still, we don't have enough uptake. We have reduced the diarrhea deaths dramatically, but we should be doing a lot more. But this is one great example of Hopkins, India collaborations that made a huge difference. Oops. Now, the other major advance in medicine, again, people don't realize. The primary care system that we use all around the world was done here by my mentor, Carl Taylor, and his group in Narangwal. And that is now being used all over the world. So India has contributed a great deal. That was in the old days, but even now, India continues to contribute a great deal. Now, I started vaccine work in India in the early the early part of 20,000. The vaccine scene in this country was extremely difficult. There was a lot of vaccine hesitancy, which still exists, of course, both in India and all over the world, also in the USA. One of the vaccines I was very interested in introducing in India was a vaccine which many of you know is known as Hib, the leading cause of meningitis. There was a great deal of hesitation. India had not introduced a new vaccine for about 2 decades. It was a tremendous challenge. Not only in India, but around the world, because what was happening was the proper lab tests were not available. People go out to the pharmacies, get antibiotics, and so nobody ever identified Hib. So governments went to the academics and said, is this a problem? They said, no, it's not a problem. We don't see it. But anyway, we formed I was fortunate enough to lead this Hib initiative by Gavi, where we collaborated with WHO, CDC, London School of Public Health, Tropical Medicine in London. And we worked very hard. It was a 5-year project, but it started in 2005. By 2010, every country was using it except China and India. It was a tremendous struggle. Then we got a grant from the Gates Foundation. It was called Enabling Environment for New Vaccines. We worked on that, and there were so many accusations against us because they felt this was foreign intervention, exploiting children. Many of our names were on the Indian Times and Hindustan, etc. Ultimately, it got introduced about 2014, 2 states got introduced, and then in another 2 years, all of the states. Now, I don't say that to complain about India. I say it because the infrastructure in India, even though it was so difficult, we had partnership with academic institutions, partnership with the local NGOs. We had partnership with local communities. We also engaged politicians. We had actually Raj Shankar, who's sitting there, was actually a program officer for this particular program that I'm talking about. We had movie stars involved. We had cricket players involved. Those people actually were much more impactful than any of us in this room because the public recognized the name and they realized it. And then it got done. The reason I'm mentioning it is India can do anything once they put their mind to it. Once that was introduced, we were able to introduce pneumococcal vaccine, rotavirus vaccine. India has one of the, this is myself with Health Minister Nada, is that the way it's pronounced? Okay. So we were congratulating each other because we'd all worked so hard on trying to get this vaccine in India. And he himself took personal interest, making sure that other new vaccines get introduced quickly. Now, India, going back from the place where we couldn't introduce any new vaccines, India is at the same time the biggest exporter of vaccines to the world. There are new vaccines that are being developed by Indian manufacturers, and I don't want to mention specific companies because it may create some issues, but India is at the cutting edge of vaccinology. Like some of you may have heard about the name Leslie Plotkin, a very famous vaccinologist. He used to say, every time we got a new vaccine, he said, remember, vaccines do not save lives. Immunization saves lives. And what I'm so excited about, in my lifetime, watching this, I think the coverage in the 70s and 80s was really abysmal, 10%, 20%. Now we have 91% coverage. That is astounding for a country of this size. You all heard about the zero-dose kids. Of course, there are some, but it's only about 7%. I don't mean to trivialize that. 7% is a lot, but we've come a long way. Soon after independence, around 10 years later, Pandit Jawaharlal Nehru said, we have done a lot, but we have a lot more to do. So that's the message I would like to leave with you. Together, Hopkins and India have done a lot, no question. But we have a lot more to do, and we are counting on the next generation to pick up the torch and run with it. Thank you.
Ladies and gentlemen, please welcome the Senior Director at Jhpiego and Associate Faculty at Johns Hopkins University, Somesh Kumar.
Good afternoon and namaste. I'll take 5 minutes of your time to share some just a flavor of what Jhpiego does in India, who we are and what we do. So obviously, after Mathu's talk, with such big legacy there, it's difficult to follow, but we'll try my best. So we are, of course, a part of Johns Hopkins University. We are more in the business of providing technical assistance to the governments in alignment with their priorities. So we are in India. A quick history of our existence. We have been providing technical assistance to government of India since 90s actually, though we opened our office in 2009. So essentially around 15 years, from 15 years we are having an office here. Today we are around 500 people. So it's a reasonably large-sized organization. We are all across the country, but more, as you would imagine, in the north, central, and northeastern part of India, where there is the most need. We started most in the women's health area, so a lot of maternal newborn health, family planning. But now we have moved on and pretty much do a lot of health system strengthening work, a lot of infectious diseases work, climate work, and tuberculosis, so cancer. So we've really expanded on the domains. India is a country of a lot of capability, in-house capability. So what do we do here when we say we are providing technical assistance? What does that mean? And so what we are trying to do over the last 15 years, we don't do any service delivery first. We try to even move away from last mile district level technical assistance to more what we call value creation. So what does that mean? If we deconstruct that jargon, we work with the government to identify what are the most important problems that you're trying to solve that is really keeping you awake in nights. Things like maternal deaths still happening during transits, MMR stagnating in some states, not going down, inequitable distribution of gender-based violence. What are those hard, hairy problems that that still plague the system, even after so much of capability inside. So that's what we try to do. And we do that in very close partnership with the government and institutions. And we use what we call 3 pillars of our effort. We call one positive disruption, so a lot of innovative solutions we try to bring, not only us, but bringing partners with complementary competence and expertise from India and beyond to have some interdisciplinary approach in one room and to solve those complex problems. And we really invest a lot in the local capacity to do what we are doing today, so that we take ourselves out of the business. So how do we do that? We have MOUs with with most state governments, with the national government. We work through strategic partnerships with a lot of local organizations. We try to have a mindset where we don't compete with local organizations, but we work with them. So it's a movement that we are all trying to make intentional efforts towards, and we try to synthesize the knowledge that we generate through high impact publications. This is a flavor of partnerships, because it's something that is very central to how we operate. So a lot of government partnerships, you can see academia for generating knowledge, generating synthesis, generating knowledge. The storekeepers of knowledge within country are academia, so how do we partner with most institutions? There's a lot of innovation capacity in India in the private sector, so we try to harness that innovation capability through strategic partnerships with groups, the innovator and accelerator enterprises, and again, partner with a lot of local organizations who bring in really huge and deep expertise in niche domains, sometimes that we don't bring to the table. We are funded by generous, all of this is possible because of generous funding from multiple funders, USAID, Gates Foundation, Children Investment Fund Foundation, and a lot of funding organizations, and some may be more than others, but we value each one of it, especially even the private sector and the small funders, because they give us what we think is a risk capital to try newer things that we can take to the rest of the world. And this is my last slide. This is our privilege. We don't see, I use it as Judd, you said, when Rajbhan sir said to you, you can't create impact if you don't work in India. And this is the privilege of working in India. The scale that you are able to create, impact in some numbers. Just we have worked in just last 4 years in supporting, strengthening up, or setting up of 70,000 primary health care centers. We have reached 11.4 million women with our maternal health interventions, 12.4 youth with our youth-based interventions, 4 million for gender-based interventions. So the scale that India affords, it's just a privilege. It's not an accomplishment, and we don't, we don't want to attribute this to us. It's all partnership. We do our little bit to contribute towards this impact. So, thank you.
Please welcome our next 2 speakers, the Senior Program Officer at the Johns Hopkins Center for Communication Programs, Uttara Bharath Kumar, and Senior Economist at World Bank, Arushi Bhatnagar.
Thank you. Thank you so much. Just to do something a little bit different than what you might expect, maybe I can ask in this room, how many of you personally is diabetic or know somebody in your family or immediate friend circle who's diabetic? Put up your hands. Okay. And how many of you know someone with a cardiovascular condition or is personally experiencing one? Stroke? Cancer? It's practically every hand in the room for everything. How about mental health? How many of you think that today, with the use of a lot of tech and a lot of time online, the young people of today are facing greater challenges? Okay, that's practically every hand in this room. So this is just to show that what we're about to talk about here is actually affecting every single person in this room, whether you're from India or not from India. And I just wanted to take us through some slightly different program. The Center for Communication Programs, or CCP, is part of the Bloomberg School of Public Health. And while a lot of it is about clinical delivery and about new techniques and medicines and so on, there's also a lot going on about behavior and social norms and all of those important things that are a part of how health happens. So the Center for Communication Programs is 35+ years old and is located within the School of Public Health. And we've been working with individuals, families, and communities around the world in 40 countries, trying to find creative solutions on how we can get at some of those really intractable social gender norms and religious norms and various things that tend to influence individual behavior. Many of us know what we need to do to prevent disease, get to screening in the right time, make sure we take the right medicines when we are prescribed. We know these things, and many of us know where to get them. Some people may not know. But despite knowing, many of us don't practice those behaviors or adopt those practices because of many things beyond our individual intention, right? Some of it is motivation, some of it is access. A lot of it has to do with what you think people want you to do or what you think people are doing, and so you should follow the norm. So this is a project about addressing those social and gender norms, and I'll hand over to Arushi, and just to say, communication is fundamental to the human experience and key to solving some of the world's most pressing problems, whether it's communication through communication interventions or through advocacy. So, Arushi?
Thank you. Thank you, Uttara. I think we've all heard about the progress India's made in improving outcomes, improving maternal and child health outcomes, as well as improving infectious disease, reducing the mortality and morbidity related to infectious diseases. And I think as we know and I think experience, as the room indicated a few minutes ago, the next frontier of challenges for India's health system are related to non-communicable diseases as well as mental health. In this context, a World Bank supported program in the southern state of Tamil Nadu focused on improving health outcomes related to non-communicable diseases, specifically hypertension and diabetes. But one of the unique features of this program was to look for solutions other than those through a medical approach. While the government of Tamil Nadu invested in improving service delivery and quality of care, they were also looking for solutions to improve and change and maybe even form behaviors for health seeking as well as treatment adherence for non-communicable diseases. And it's in this context that we had this wonderful partnership between Johns Hopkins Center for Communication Programs, the government of Tamil Nadu, and the World Bank to conduct formative research to find answers to some of these barriers at the individual, institutional, as well as the societal level for improving health-seeking behavior and treatment adherence for non-communicable diseases. I'll let Uttara talk a little bit more about the program, but just to say that this is, again, in the spirit of the meeting today, one of those collaborative efforts that has just begun, and we hope that there are various phases to it and lessons learned that we can share going forward. Thank you.
Thanks, and this is a very brief overview of a very big project. So just to say that there are multiple levels at which these barriers occur: individual, social, institutional, and structural. So we set out together with our sister organization, Center for Communication and Change India, based here in Delhi, and we discovered several of those barriers and worked on how to address those. And the key thing was we involved people from the community, the health providers, various people in government, as well as community leaders, to really workshop those insights to see how we can work with them and develop a communication strategy. And what really emerged was fascinating because the social and behavior change communication strategy that the government of Tamil Nadu put together based on these insights and what came out of the discussions is probably the first officially adopted communication strategy for non-communicable diseases in India, as far as we know, and probably anywhere in the world. We did a lit review. There isn't really another specific communication strategy for something that really affects us all. So we're hopeful that, in adopting it, that this is going to have budget line item put towards it and actually implemented and taken forward year after year. So this is something we are incredibly proud of in this partnership. And also to say that we're both also alums of Johns Hopkins as the extra piece of this story. So collaboration comes from multiple layers. Thank you very much.
Please welcome the co-director of the Johns Hopkins Center for Infectious Diseases in India, Vidya Mave.
Okay, thank you. On behalf of my co-director, Sunil Solomon, Executive Director, Managing Director, Katie Zook, and the colleagues at Citi, it is my honor to present our program. Our center is housed within the Division of Infectious Diseases at the Johns Hopkins School of Medicine with the teams based out of Chennai, Pune, as well as Delhi. Our mission is to improve health outcomes and ensure equitable access to healthcare among people who have infectious diseases through research, education, and community-based partnership. Our work in India began with two key partnerships which was established by Johns Hopkins investigators, one in ICMR's National AIDS Research Institute in Pune, and the second one in YRG Care, Chennai. However, over the past 30 years, our program expanded across multiple states with key partnership among academia, government institutions, as well as community-based organizations. The 7 faculty associated with our center have received over $80 million funding within the past 5 years from sponsors such as National Institute of Health, Center for Disease Control, USAID, and UNITAID. We also have a only DATE-certified program for clinical infectious diseases in India as part of Baltimore, India Clinical Trials Unit of Johns Hopkins University. Our faculty also have received 2 NIH Directors Award within the past 5 years. Our work in India is guided by ethics committees and community advisory boards and has evolved with the evolving needs of the communities we serve, and it's in line with Indian government as well as global priorities. We work across the spectrum with discovery to development of guidelines and implementation of the guidelines into practice. For example, our work in clinical trial space, especially in tuberculosis, include identifying therapeutics for TB prevention, treatment shortening of TB treatment from 6 months to 4 months or less, and as well as identifying the implementation strategies required to put those guidelines into practice. Our CDC-funded study looks into antimicrobial resistance, wherein we are identifying strategies, ground-up strategies to reduce the antimicrobial resistance, wherein there are hardly any treatments are currently available. In implementation science space, we are evaluating strategies, community-based strategies to deliver medications or prevention strategies to vulnerable populations. We have also conducted several surveillance projects for dengue, chikungunya, and SARS-CoV-2. We have been able to accomplish all of this by leveraging our expertise across various schools in Johns Hopkins, and we would also are hoping to expand these collaborations with engineering and business schools as well. We offer volunteer opportunities for our undergrads, medical students, as well as doctoral students who wish exposure to global health. Our work has been impactful over the last 3 decades. Our first study was conducted in early 2000s, which was the first clinical trial to prevent mother-to-child transmission of HIV, which became a World Health Organization guidelines, wherein several national programs have implemented 6 weeks of externeuropine to HIV-exposed infants and saving millions of lives. We also recently participated in 2 treatment shortening trials for tuberculosis. As you know, India has the world's largest absolute burden of TB, and the Indian government has an ambitious goal of eliminating TB in India in the next 5 to 10 years. These trials have become now a part of the WHO guidelines for treatment of tuberculosis. We also have partnered with National AIDS Control Organization in developing guidelines for pre-exposure prophylaxis of HIV, and with our partner Institute of YRG Care, as well as Abbott, we have a new program called Blue Shed program, which provides opioid substitution practice to people who inject drug. In addition, we have recently established a Mitra clinic, the first transgender clinic in India, which provides general health care as well as gender-affirming care, HIV prevention care, and so on. And this program will be shortly taken up by the government of India, and we are thrilled about that. There is a significant need in India to advance clinical research and to develop next generation of young researchers. India does have a high-quality academic institutions as well as a great human talent, but research investment is sorely needed. With generous support of GKII donors and Indian partners, our center is partnering with YRGK Chennai to establish a research center in Pune that will have a training center, data center, and the state-of-the laboratories. In addition, CD has partnered with YRGK Chennai to develop laboratory infrastructure in Chennai. I want to end my talk by thanking our multiple partners in India, as well as our donors who believe in us and in our mission. Without their support, none of this would be possible. And also acknowledge the tireless work of our faculty as well as research teams in India who strive to advance science one participant at a time to save lives. Thank you.